Thank you for the introduction, Megan. Very excited to be here talking with you all today, especially because I'm from Kentucky. I'm from Syersville, which is in eastern Kentucky at the end of the Mountain Parkway. So it's always nice to be talking to a group of fellow Kentuckians. So I will share my screen now. All right, can you all see that okay?
Yes.
All right, great. Megan invited me to speak after she came to a talk that I was giving on catatonia at the American Psychiatric Association meeting last year. And this is a topic that I've been interested in for a long time. So after I wrapped up training, I worked on an inpatient psychiatric unit. It was an acute psychiatric unit for a few years before I transitioned to primarily outpatient last year. And in that position, I found pretty quickly that I had not learned a lot about catatonia in residency, other than sort of theoretical descriptions of it, and seen a couple cases. But once I was on the ground in the trenches, I realized that this is a lot more common than the way that it's typically presented in didactics. Many people think of catatonia as the state where a patient is mute and totally immobile, and that really only captures somewhere between 10 and 20% of catatonia. So it's a condition that's extremely underdiagnosed, and it's one in psychiatry where if you miss it, it really can be life-changing or even life-ending for the patient. And so I set out on this quest to learn as much as I could about this condition, and to also share that knowledge with other people. So I've been giving a lot of talks on catatonia, and I hope you all find this useful today, and it will generate some helpful discussion. So these are my disclosures. None of these are relevant to catatonia. There's not really any interest in the pharmaceutical industry in treating this condition, unfortunately. So everything that we use is off-label. So all the medications that I mentioned today will be in terms of off-label use. I'd like to start out by talking about the diagnostic challenges related to catatonia, since the diagnosis is so often missed. Then I'll go over the associated morbidity, talk about mortality risks, and wrap up by talking about management options, as well as what can be done to prevent some of the potentially devastating complications of catatonia. I will begin with some epidemiology, move on to diagnosis and the challenges there, go over the morbidity and mortality, and then talk about management at the end. Before I start, I just want everyone to know about the resources that are being put together by the University of Rochester. So it's Mark Oldham and Josh Wartzel. They've been doing incredible work there, doing a lot of research around the diagnosis of catatonia, and also preparing videos on how to diagnose catatonia with specific videos for each of the catatonic signs on the Bush-Francis catatonia rating scale. And I highly suggest that you check these videos out, because the terminology around catatonia can be confusing. It can be hard to understand how to identify certain signs, and so they're doing really important work. And they've also created an app that essentially is the Bush-Francis catatonia rating scale, so you can use that at the bedside to diagnose a patient and collect their scores on that. All right, so on to epidemiology. Catatonia looks like it occurs somewhere between 10 and 30 episodes per 100,000 people per year. We think this is also probably an underestimate due to underdiagnosis, and the frequency or the incidence is higher in adults than children, which is not surprising, since bipolar disorder usually comes on in the late teens or 20s. So there's about a 4 times difference there between adults and children. The prevalence of catatonia has been assessed in a lot of different patients over the last century or so, and Depending on the population, you can get pretty wide-ranging numbers. For psychiatric inpatients, it goes from anywhere from almost 10 to 40%, depending on the type of unit. There was a study done of psychiatric outpatients with depression that found that 20% of them had catatonia, and another study of patients with non-affective psychosis who'd never been treated, a little bit higher than 10%. I would say on most mixed psychiatric units, it's probably around 10%. But if you have a unit that's dedicated to patients with psychosis, mania, severe mental illness, the number is probably going to run higher, possibly up to 20% or so. Catatonia is also something that can occur during mania. I think it gets missed a lot in mania because the focus is typically on the patient's manic behaviors, but about a quarter of patients have been found to have excited catatonia during these episodes, and it most often occurs during mixed manic episodes. And so that can actually be a useful sign for you if a patient is manic and they have catatonia, then you're probably dealing with a mixed episode. And this is a breakdown in this chart here of the frequency of various catatonic symptoms in patients with mixed mania. So they have catatonic excitement, verbigeration, stereotypies, periods of motor inhibition. And so this definitely tends to be on the other end of the spectrum from the hypokinetic form of catatonia that most people more easily recognize. Catatonia is also an important consideration in postpartum mental illness. So there have been a few studies looking at this and have found rates around 20 to 30% in women dealing with postpartum conditions. And in the studies where this has been looked at, there's pretty good response rates to lorazepam, which is a first-line treatment. However, the response appears to go down for the longer the duration of catatonia, which we see that with catatonia in general. And if women with this don't respond to lorazepam, then they usually respond to ECT. And when it occurs in a postpartum context, it's usually within the first few weeks postpartum that these women start to have and manifest psychiatric conditions. Catatonia is also an important consideration in child and adolescent patients. This gets missed quite a bit, unfortunately. I think we still have a long way to go to improve the recognition of catatonia in childhood. But this photo here is from a video online. Some parents were asking what was wrong with their child, and they couldn't get a diagnosis. And just from seeing this video, this wasn't my patient, so I can't officially make the diagnosis. But this to me looks like catatonic posturing. And so there have been studies, evaluating the prevalence and rates of 5% just in psychiatric intakes. For the first time seeing these patients, and rates going as high as almost 20% in patients with psychosis. And we see catatonia frequently in patients who have intellectual disabilities, developmental disorders, and so it's always an important consideration there. Although my experience is that it's often harder to treat when there's comorbid conditions such as those. All right, so on to diagnosis. We know that there is a struggle within psychiatry to accurately diagnose catatonia. And so this was work from the University of Rochester, where they did a study of almost 500 psychiatrists and trainees, and they gave them standardized patient videos and a multiple choice test. And they found that respondents missed a number of these questions, didn't recognize catatonic signs in the videos, and pretty surprisingly, psychiatrists didn't do that much better than trainees, either on the multiple choice test or on the scoring of the videos. And that's a pretty alarming finding. And the most commonly misidentified items were ones that to me wouldn't necessarily seem to be that hard to diagnose, as someone who's seen a lot of patients with catatonia. But it was rigidity, mannerisms, which are strange behaviors, echopraxia, echolalia, so copying staff's behaviors or what they're saying, perseveration, staying on a particular topic over and over, and ambitendency, this hesitancy where patients are stuck in their decision making. And that study found that older participants performed worse than younger participants. And so I think this is a reflection of improved education around catatonia that's happening now. I do think that trainees are getting a lot more exposure to this now than they were decades ago. So the underdiagnosis of catatonia has been captured in a lot of patient populations, including general hospital populations, adult psychiatric inpatient facilities, child patients, neurology patients. You can see here the numbers are pretty striking. Often, somewhere only around 10% of patients with this are getting diagnosed. And there's a real challenge with neurology. I find that colleagues in neurology just don't seem to know a lot about catatonia and don't recognize it. And I've treated a number of patients who were referred to me for Parkinson's disease, and I, would start them on lithium, because catatonia is most often related to bipolar disorder, and they have a full recovery. So it's very satisfying to see cases like that, but it's also very frightening to think about the scale at which this is happening. Catatonia is also a significant problem in the intensive care units, and so there's been an increasing number of papers written on this, and so it's something to keep an eye out for. And we'll touch on this more later when we talk about catatonia and delirium. This was a study done a few years ago. It was really kind of a novel idea. It was the authors wanted to retrospectively diagnose catatonia from the charts to see how often it was being missed. And so they were looking for evidence of the various signs of catatonia and recording that and scoring that. And they found that a number of patients had catatonia and it had been missed. And there were pretty clear signs from the chart that strongly suggested the catatonia diagnosis. So you can see some of the phrases here, and I've definitely seen these in charts myself, in reviewing charts before I go to see a patient. And when I see phrases like this, catatonia is already on my radar before I even see the patient. Another challenge with the diagnosis of catatonia is that the signs are dynamic. So, when we think about catatonia, we often think about patients with hypokinetic catatonia who aren't moving, aren't speaking. They seem to be not changing really in any way. And that is actually not the right way to think about catatonia. So even Kalbaum, who first conceptualized catatonia, recognized that many patients had catatonic signs that would appear for short periods, and then they would go away, and then they would recur. And so this is a big cause of disagreement among clinicians, because a patient might have different catatonic signs depending on when one clinician sees them versus the other, or the patient might be out of their catatonia and then back into it when another clinician comes to see them. And incredibly, there's almost no literature on this phenomenon. It's just sort of referenced in case reports and case series. And so with that in mind, I collaborated with Andrew Francis, who created the Bush-Francis Catatonia Rating Scale, to take a look at this. So we decided to evaluate patients' catatonic signs over a 24-hour period on our inpatient unit here at Lutheran Hospital. And so there were 26 patients. I did a Bush-Francis exam on them during morning rounds, at the end of the workday, and then the following morning. Now, this is a hard study to do today because many patients, even if catatonia is not diagnosed, they're exposed to agents that could affect their catatonia and its manifestations. So many patients, are simply treated as if they have psychosis, so they're started on antipsychotics, which can worsen catatonic signs. many patients, when they get agitated, they get benzodiazepines that can inadvertently make the catatonia better. And so that's a challenge to doing this work now. And it's a shame that nobody did a study like this, 40, 50 years ago, before there were medications being used to treat this condition, so that we could have a more clear picture of it. But luckily for us, there were a few patients in this cohort, I think 5, who were not treated at all with any sort of agent that would affect their catatonia during that 24-hour period. And so we report data for both, for patients who are being exposed to agents that could affect their catatonia, and patients who were not exposed to any. And this was the population. So patients were about 40 years old, primarily male, mostly white and African American. Bipolar diagnosis was the most common diagnosis. There was a good bit of substance use. And these patients stayed about 3 weeks on average. That's another sign that you're probably dealing with catatonia, is these patients often stay much longer than the 4 or 5 days that we see for a typical inpatient psychiatric stay. So the Bush-Francis scores are here. So to start out with, on average, patients typically had a score of 11, and that went down to around 8 at the next measurement time points. They had an average of 6 signs at the beginning. Those went down over time, since most of the patients were being treated. But interestingly, here you see that the total number of signs experienced over the period, the average for that was 7. So that alone tells you that at some point patients typically had a sign that wasn't present when they first came in. So these are the most notable results. This paper's in press. It isn't out yet, but hopefully it'll be out in the next few months. We found that all patients experienced at least one change in at least one catatonic sign over that period. So that could be disappearance of a sign, emergence of a new sign, a change in laterality, or a change in severity. And among the untreated patients, their Bush-Francis scores were higher at the morning time points than the evening time point, suggesting that catatonia might actually be more severe in the morning, which is consistent with many patients that I've seen, and their families have commented on that as well. So there seems to be a diurnal, possibly a circadian element to catatonia. Among the untreated patients, about a third of signs were noted to disappear in the evening, and then reappear at the following morning in at least one patient out of that group of 5. And where we had scores available for all time points, a small number of patients actually lost catatonic caseness. So that means they no longer met the diagnostic criteria for catatonia in the evening, and then it came back in the following morning, and this occurred in one of the 5 untreated patients. So it looks like this is a phenomenon that is independent of treatment status. That really is a core feature of the catatonia. But obviously, we need bigger studies to look at this to confirm these findings. So I have this table here. Obviously, not going to go into a lot of detail about this, but the point is just to show you that for all these different catatonic signs, there was a significant number of patients in every group. So either the whole sample, the untreated sample, or the treated sample, who experienced changes in the presence or absence of each of these signs over the interval. So you can see for almost every sign there was at least one patient who had that sign either go away if it was there at the beginning, or it came back, or it came on new during the second or third evaluations. An important takeaway from this study is to do a bilateral motor exam. It turned out that patients had a lot of changes in the laterality of their signs, even in the untreated group. So they might have posturing or catalepsy on the left side during one exam, and then the next exam it would be on the right, or it would be bilateral. And so if you're just doing a motor exam on one side of the body, you could be missing some of these motor findings of catatonia. Now, an important question, in considering all of this is, what's the right diagnostic threshold for catatonia? And I think this is, an important question, and probably the biggest kind of practical question that we have to deal with clinically. So if you vary the number of signs that you use in the diagnosis, obviously there are big differences in prevalence in the number of patients who have catatonia, and so you see that that varies widely. If you go from using one sign to three signs. The Bush-Francis catatonia rating scale requires two signs, while the DSM requires three signs. And typically, in research studies, they require four signs to really be certain that it's catatonia that they're looking at. So I think in general, you know, three signs is probably the right way to go. I think the DSM got that element correct. I do see signs. I do see patients with two signs of catatonia, and try to treat that, and sometimes nothing much really happens, and so it can be hard to tell. I think where the DSM gets it wrong, though, is it leaves out a number of potential signs that could be used, and so you can't just go on DSM criteria alone. And so another important question is, well, which signs do we use? Callbaum initially described 17, but there are now 40 or so recognized catatonic signs. So I'll just briefly go through what's on the Bush-Francis catatonia rating scale. So there's immobility, stupor, mutism. The patient isn't talking, or they're whispering. Staring is something that we see commonly. Posturing. So this is when patients are in a posture. When you approach them, you can see that from far away. Whereas catalepsy is when you raise their arm or their leg, and it stays in place, or it comes down very, very slowly. Grimacing. So this is when patients are having odd facial expressions. It's often a look of fear. They look very frightened, but sometimes it can be smiling. Echopraxia is where they're mimicking speech. Mimicking behaviors. Echolalia is where they're mimicking speech. Stereotypies are repetitive movements that are not necessarily abnormal in the movement or behavior themselves, but in the frequency. Somebody might snap their finger. That's not that unusual, but if they did it, multiple times, that would be a stereotypy. Mannerisms are inherently odd. The examples listed here, things like walking on tiptoe or saluting people. Andrew Francis says that mannerisms don't pass the subway test. If you see somebody on the subway and they're doing something and you think that looks weird, that would be a mannerism. So there's also stereotypic speech, which is referred to as verbigeration. Patients will repeat phrases or sentences over and over. There's rigidity. It is important to exclude cogwheeling or tremor when you're looking for that. Negativism. So patients can either refuse to cooperate with you, or they will do the exact opposite of what you tell them to do. Waxy flexibility is often confused with catalepsy, but this is when there is an initial resistance to trying to move the patient's limb, and then you break through that, and all of a sudden it's very easy to move that limb to another location. Withdrawal. So patients with catatonia often aren't eating, aren't drinking much. They stay in the room. They aren't making eye contact. Catatonic excitement. So this is extreme hyperactivity. These patients often can't sit still. They're up, they're pacing on the unit all the time. And this is different from mania. Of course, we know that manic patients have a lot of energy as well, but that's goal directed. So catatonic excitement is not goal directed. So that's the screening portion of the Bush-Francis catatonia rating scale. If you use the criteria of that instrument for diagnosis, a patient needs to have at least two of those, and then you would go on to the full exam to get the full score. And so moving ahead with that, impulsivity is a very important component of catatonia. I've seen patients definitely running, trying to get off the unit, trying to knock down the doors. Patients have had impulsive suicide attempts, jumping out windows, jumping off bridges. So it's really an extremely high level of impulsivity. Automatic obedience. So this is when patients are told to cooperate with the request, and they cooperate without question. Passive obedience is also referred to as mitt gain. So you have them stick out their arm, and you say, Don't let me raise your arm as you move your finger towards their arm, and sometimes this is so severe that they start moving their arm before you even get your finger to touch it. Gegenhalten, or muscle resistance. This this is a variable resistance that increases with the speed of movement. So if you're moving slowly, there's not that much resistance. Then you move quickly, and it can be impossible to make any further movement. Ambitendency, so this is when patients are stuck in indecisive, hesitant motor movements. I would say this also applies to cognition as well. Sometimes these patients, they just can't even get up out of the chair to leave the room, or they keep coming back to the door over and over. So they're just kind of stuck in terms of figuring out what they want to do next. Grasp reflex is also important to check for. Excuse me. Perseveration. So this is when patients come back to the same topic over and over, or they persist with the same movements. And then combativeness is something that we see sometimes with catatonia. It's one of the least common findings, but unprovoked aggression always makes me think about catatonia. And then the final sign is autonomic abnormality. I think this is something that people forget to check frequently when they're trying to determine whether someone has catatonia or not. But it's important to note that catatonia doesn't just cause hypertension or tachycardia. It can also cause hypotension, and I've seen a lot of bradycardia, that's otherwise unexplained in patients with catatonia. These are some helpful points listed here on conducting the Bush-Francis catatonia rating scale. So they have some examples that you can use. For example, if you're looking for echopraxia, you can scratch your head in an exaggerated manner and see if the patient mimics that. I have successfully used that a couple of times. There's also checking for ambitendency. You stick out your hand, you say, "Don't shake my hand." And so the patient is stuck trying to do both things. They're not able to recognize that the verbal command should override you sticking out your hand. When you test for automatic obedience, classically you would say, "Stick out your tongue. I want to stick a pin in it." I actually don't use this anymore because I found that patients on our inpatient unit, some of the ones with psychosis, got very frightened when I did this, and it really hurt rapport with those patients. So now what we do here is we ask patients to bite something that's aversive. So if there's a tissue box sitting there, I'll pick that up and say, "Bite this for me." And most patients will say, "That's disgusting. That's a tissue box inside of a hospital. I won't do that." But the patients with automatic obedience, they might give you a funny look, but then they'll move towards the box. And I did have one time where a patient did this, and or where a resident did this and didn't remove the box quickly enough, and the patient took a bite out of the tissue box. So make sure that you pull it away quickly. But I think that is the best approach to doing that, especially when you're dealing with patients with psychosis. All right, so these, in contrast, these are the DSM criteria. So as you can see, there are far fewer to choose from. You have 12, and it's actually even less in the Bush-Francis exam, because echolalia and echopraxia are separated. Let's see, similar to that, catalepsy and posturing are separated as well. And so really you're working with way fewer signs to make this diagnosis here. And I think if you just use the DSM criteria, you're going to miss a lot of patients with catatonia who could benefit from treatment. This was a study done by Joel and Wilson at Vanderbilt. They've been doing a lot of really important work in catatonia there. And so figure A there shows the frequency of catatonic signs that they encountered. So staring, stupor, mutism, withdrawal, those were the most common ones. Whereas combativeness, grasp reflex, mannerisms, echopraxia, echolalia were the least common, and that's consistent with my clinical practice as well. The modal number of signs there was 6. So most patients who have catatonia, it's not equivocal. It's not like you're dealing with 2 or 3 signs and you're on the cusp trying to make that diagnosis. That happens sometimes, but usually when they have catatonia, they have a lot of signs, and so if you're doing the standardized exam, it's pretty easy to make the diagnosis. And then figure C there, they looked at how removing particular signs would affect catatonic caseness, so would make the diagnosis of catatonia go away. And the sign that was most important there was staring. So if you remove staring, then about 4% of patients in this cohort didn't have catatonia, and that's a really important observation because the DSM criteria do not include staring, and so there's been a lot of criticism there saying that staring really needs to be added to the DSM criteria. So these are just some of my observations from clinical practice on behaviors that might suggest catatonia. One of these is a focus on water, which can also suggest delirious mania, which is not in the DSM, but I think it's a useful diagnosis. But many catatonia experts argue that delirious mania is just a form of catatonia anyways. And the treatment there is the same. It's either benzodiazepines or electroconvulsive therapy. But if you're on an inpatient unit and you see patients flushing their toilet over and over, pouring water from one cup to another, just playing with water in the sink, you really need to be thinking about catatonia. Nurses will often refer to inappropriate smiling in their notes. That's usually a sign of catatonic grimacing. There's been a lot of work done around increasing the recognition of incontinence as a sign of catatonia. If you see incontinence, especially in adults, that's very, very unusual, and that's not typically associated with psychosis. I mentioned before, evidence of extreme impulsivity should make you think about catatonia. There's the psychological pillows. So there's two photos of that there where it's as if the patient is sleeping on a pillow, but their head is actually above the pillow and not resting on it, or there's no pillow at all under them. Um, uh, Rapid blinking, finger play, repeating words or phrases, these can be stereotypies. If a patient refuses to allow you to examine them or to answer your questions or to take medications, that's catatonic negativism until proven otherwise. I see a lot of issues there where the resident will admit a patient overnight and say, the patient didn't want to talk to me. They're in their room. They're not cooperating. This is obviously psychosis. So I just restarted their antipsychotic. That is not what I would do in that case. If a patient is not cooperating with me, then the first thing to do is start lorazepam, even if you can't get a Bush-Francis exam. Removing clothes, that can suggest impulsivity. If they're having perseverative behavior, coming back to the door over and over, if they're unable to let go, if they shake your hand, then that can be a sign of perseveration. Random violence in the community can be catatonic combativeness. So every once in a while, we see a patient who was admitted because they just punched someone on the street for no reason, or they randomly attacked someone in their nursing home. I always think about catatonia in those cases. Selectively nonverbal is something that shows up in the chart a lot that can indicate mutism. I find that nurses often think this is volitional. The patient would only talk to this person. They wouldn't talk to me. This is behavioral. We should discharge this patient. That is a sign of catatonia. Doing negativistic things, so things that we see frequently here are sleeping on the floor instead of their bed, or we have mattresses that can be removed from the bed frame here, and so the patients will take the mattress off and put it in the floor. So doing the opposite of what you would expect. Withdrawal if they're staying in their room, not talking to people. If they can't sit still, if they're pacing on the unit, that's could be a catatonic excitement. And then mannerisms are listed here. So walking backwards, walking on tiptoes, saluting. I saw a patient who was standing by the wall, like pretending he had a key and it was a door. Very strange movements, speaking in a foreign accent or like a robot. That's manneristic speech. And there are a lot of different speech manifestations of catatonia. I won't go into all of them, but somebody did a paper on this, and it was really impressive to see all of this pulled together. But I think the most important ones to identify are manneristic speech. So this is having a foreign accent if they've never had one, or talking like a robot, talking like a child or a baby. And then speech prompt catatonia. So this is when patients answer your questions, answer them all the same way. They say, I don't know, I don't know, I don't know, or they say yes or no to everything. And so this can be seen as the patient's being uncooperative. Maybe they're malingering, but this is actually called speech prompt catatonia. And so it really should clue you in to get lorazepam started. This was a cool paper that was done about a decade ago where they recognized sort of broad phenotypes of catatonia in the hospital. And I would say that this is consistent with what I've seen. So there's the one called the distant mute. So these are patients who have classic catatonia. They're not talking, they're not moving, they're withdrawn. Then there's the waxy stiff. So these patients tend to have more motor manifestations. So they have catalepsy, waxy flexibility, rigidity. Then there's the broken record. So this is patients who they have excitement, but they're also very kind of verbally focused. They have verbigeration, they have echo phenomena, and then the stubborn grouch. So this is, I think these are the patients where catatonia gets missed the most. They are negativistic, they're not cooperative. Doesn't seem like they want treatment, and so oftentimes they're just just kind of seen as being not interested in getting care, and they don't stay very long. They're kind of discharged in the same state that they came in with. But if you look closely, these patients often have repetitive movements, so stereotypies, mannerisms, and catatonic excitement during periods. There can be laboratory evidence to help support the diagnosis of catatonia. Serum iron levels have been found to be low in patients with catatonia. There is some debate about this, though, because most of the patients, most of the studies that have been done have been comparing these to normal populations, and then the difference is less pronounced when you compare them to other psychiatric inpatients. But I would say this is something that I've seen quite a bit. So I do check serum iron level in patients where I suspect catatonia, and that does look like it's associated with poor benzodiazepine response and more commonly observed in patients with excited catatonia. Transferrin levels can also be low. These patients tend to have high creatine kinase levels, especially if they have excited catatonia and they're moving around a lot. The CK level can also be increased by intramuscular injections. So if you are using intramuscular lorazepam instead of IV, you can get a false inflation there that can throw you off. And catatonic patients also have higher D-dimer levels, and so it really does look like it's a pro-inflammatory state. CRP levels also appear to be higher, ceruloplasmin levels, homovanillic acid, higher levels of neutrophil to lymphocyte ratio, and higher levels of white blood cell counts. And so there's a lot of interest now in exploring whether catatonia really is some sort of autoimmune condition or syndrome of immune dysfunction because of findings like this. So these are the labs that I typically get when I'm treating patients that I'm concerned about catatonia. We always now have to check for anti-NMDA receptor antibodies. You can check those in the serum, but that's not perfect. And so sometimes if there's really a concern for that, you have to do a lumbar puncture. It's always good to get an EEG since seizures can cause catatonic manifestations. And we don't typically get neuroimaging, but if it's a tough case, can't figure out what's going on, then you want to rule out things like stroke, space occupying lesions. So in terms of phenotype, catatonia is primarily divided up into excited versus hypokinetic, also called retarded form. And so the hypokinetic form is more common than the excited form, but it looks like there's a big chunk of patients who have both, or who actually cycle through both. It does look like excited catatonia might be less responsive to benzodiazepines, so that's important to know if you do see that. And excited catatonia does appear to be the predominant form of catatonia when patients have anti-NMDA receptor encephalitis, and they have catatonia with that. So excited catatonia, these patients, they just won't stop moving. They're often getting tons of intramuscular injections of benzodiazepines and antipsychotics. Primary teams don't know what to do with them. if you run across cases like this where there's just extreme agitation that doesn't make sense, you really want to try to use benzodiazepines to get this under control, because it probably is excited catatonia. And as I mentioned before, it's not goal directed. This was a nice case report done by one of my colleagues, Nora Burns here. They showed how a particular patient's catatonic manifestations moved between excitation and stupor over the course of a 3-week inpatient stay. And I think that really nicely captures the fact that many of these patients move between the excited and the hypokinetic forms. But I would say in general, we don't see sort of the flagrant excited catatonia as much now, because those patients usually wind up in the emergency room first, and they're given IM antipsychotics and IM benzodiazepines, which the latter of which probably gets the excitement under control. So by the time they come to the inpatient unit, they don't have that particular manifestation of catatonia. It's also important to note that increased levels of catecholamines during catatonic excitement might cause hypercoagulability. And so I'll discuss this a little bit later, but even if patients have an excited form of catatonia, you want to definitely be working to prevent DVTs or pulmonary embolisms. Malignant catatonia. So this is a life-threatening version of catatonia. It used to be called lethal catatonia because it was so fatal, but now we have treatments for this. And if patients are treated quickly, they tend to respond well, but it can progress very rapidly. So you have to get things under control quickly, and it's usually marked by fever, delirium, and autonomic instability. And this table here has the various characteristics that you can see. Patients will also often have very high CK levels, leukocytosis, low iron levels. The incidence of malignant catatonia in psychiatric inpatients, it's pretty low, but the mortality is high. So it's in this cohort that they looked at here, it was 15%, and a higher mortality rate in patients with more severe malignant catatonia. And this is how they classified it here. So it's a pretty simple classification system to use in clinical practice to let you know how quickly you need to be moving. But if a patient has any 2 or 3 of these signs here: rigidity, elevated temperature, impaired consciousness, then that indicates severe malignant catatonia, and you really need to move to ECT as quickly as possible. So this was a study looking at treatment response in malignant catatonia. And so patients got various treatments. So they could get a combination of benzos and ECT here, just a benzo here, ECT, antipsychotics, and supportive therapy. So obviously this was an observational study. It wouldn't be ethical to do this study as an RCT. But the mortality rate was much higher in patients who got just supportive care. So it was nearly 75% of those patients died. If they just got antipsychotics, more than a third died. And the lowest mortality rate, which was 0, was for patients who got both a combination of benzodiazepines and ECT. So you still want to keep benzodiazepines going if you're thinking about a malignant catatonia diagnosis. You want to get ECT, but that often takes time to set up. So start benzodiazepines right away. And that study also found that when benzodiazepines were started faster, the rates of remission were higher, whereas the patients who died, it tended to be 10 days or so before a benzodiazepine was started. Catatonia is almost always caused by another medical condition. So it's similar to delirium in that way. It's usually a mood stabilizer, most often bipolar disorder, in contrast to schizophrenia, which was thought to be the most commonly associated disorder in the past. But there's still a big chunk of patients who have psychotic disorders, and about a fifth of cases have an underlying medical non-psychiatric diagnosis that's driving the catatonia. And this is most commonly found in patients who don't have an existing psychiatric history and they have a history of seizures. So there have been multiple studies looking at the probability of medical catatonia in patients in various settings who have catatonia. And so you can see that the rates get pretty high there, especially in older patients who are on a CL service. If they have catatonia, it's much more likely to be due to a medical cause than a psychiatric cause. All right, so now on to catatonia and delirium. So this is a controversial area because the DSM says that you can't make the diagnosis of catatonia due to another medical condition if the patient also has delirium. But it turns out, based on work by Wilson and colleagues at Vanderbilt, that catatonia and delirium are highly comorbid. So they found in 200 patients with delirium that about a third of them had at least two catatonic signs, and more than 10% met DSM-5 criteria for catatonia. And they found that this most commonly occurred in female patients and patients who had delirium before they were admitted to the hospital. And patients with catatonia, they had higher frequency of motor retardation on their delirium assessments as well. And so there have been growing calls to remove this exclusion so that we could, officially be able to diagnose delirium and catatonia together. But I won't lie, it's a challenge to manage both because potentially benzodiazepines could worsen delirium if you're trying to treat the catatonia. But if you're using antipsychotics to manage agitation in association with the delirium, then that can make the catatonia worse. ECT can treat the catatonia, but that can make the delirium worse. We still have a lot to learn about this, but it looks like the sort of the middle ground is to use memantine in these patients to treat the catatonic element. So I think it's interesting to think about how long catatonia can last if it's not treated, and we actually do have older studies where patients with catatonia were followed for long periods, and a significant number of those patients had catatonia that lasted potentially for years. And from the asylum days, the recovery rates from catatonia were less than 50%, and so many of those patients just continue to have catatonia for the entire observation period, which could be decades or their entire life. So this is a condition that for some patients is not going to go away if you miss it. Recurrent catatonia is a really, really important issue. So it looks like about a quarter of patients who have catatonia will go on to have another catatonic episode. So this is something that I always tell patients when I'm treating them on the inpatient unit. If they have this diagnosis, it's the first time they're coming in, I tell them there's about a quarter chance that you're going to have this again. And so that can be useful for patients so that they recognize what's happening. You can let their family members know. Recurrence tends to be more common if they have an underlying psychotic disorder. And there was a study done looking at the interval, and it looks like in patients with recurrent catatonia, it's about a year-long interval between episodes from that particular study. There was a larger study done that was published a couple years ago, and they found it was really, really interesting. So they had 1,500 patients with catatonia. They found that the number of episodes ranged from 1 to 27 over a mean follow-up time of 7 years, and the mean was 1.5. And they calculated the rate of episodes per year, which is listed there, and a quarter of patients experienced at least 2 episodes within the follow-up period. Importantly, they found that in patients experiencing 5 episodes over that period, more than half of them would go on to have another episode within that period. So if a patient has had multiple episodes of catatonia, then they really need to either be on lithium, because that's often bipolar disorder, or a standing benzodiazepine. And so this gets to the question of periodic catatonia. So this was a type of catatonia that was recognized in the past. It's harder for us to recognize now because many patients are getting treated for other psychiatric conditions. So they're on medications that could prevent the recurrence of catatonia. But 100 years ago, there were patients who would just have catatonia. It would resolve, and then it would come back, and they didn't have any mood episodes in between. Now I've talked to experts in the field, and they really feel like that this is a form of bipolar disorder where the only manifestation is catatonia. And I think that makes sense because the treatment that's been found to work best is lithium in these patients. So if you are seeing patients with periodic catatonia, um, then you want to try to use lithium first. And I've had some very dramatic recoveries and cessation of recurrences when I've done that with patients. It also looks like even if it doesn't reduce the number of episodes, it will prolong the interval in between them. And periodic catatonia or recurrent catatonia more commonly has a family history of catatonia than just catatonia in general. So this really does seem to be something that probably has a genetic component or some sort of heritable psychological component that's driving this. But yeah, when you talk to these families, these patients, you'll often hear them say that someone else in the family has had this before. All right, so on to morbidity and mortality. Catatonia can have a lot of complications, and these can be pretty devastating. So things like rhabdomyolysis, pneumonia, urinary retention, dehydration, urinary tract infections, DIC, sepsis, arrhythmias. And you see this column over here, the time interval varies a lot. So, rhabdomyolysis, pneumonia, urinary retention, dehydration, these are things that can come on pretty quickly after the catatonia starts. Whereas your risk for things like DIC, decubitus ulcers, and sepsis, this is usually when catatonia has not been recognized or treated for a few weeks. I mentioned before that there's increased odds of DVT in catatonia. So there was a study here where they found that if you had catatonia, your odds of developing a DVT were 3 times those of other psychiatric inpatients. And then in this study here, they found a fourfold increase in the risk of catatonia versus patients who got restrained during a psychiatric stay but did not have catatonia. They used that as the control. So that was statistically significant. It was not significant for excited catatonia, but the odds ratio was 2 there, and it was a small sample. And so I do think there still is increased risk for DVT and pulmonary embolism, even if it's excited catatonia, although it's not to the same degree, obviously, as if patients aren't moving. And so here's a case report consistent with that. It was a patient with excited catatonia who had a fatal pulmonary embolism. Now, an important question is, if a patient has catatonia and they have DVT, obviously you still want to do everything that you can to treat the underlying catatonia. So is ECT safe in these patients? And so this was a case series where they looked at this, and there were no complications except for one patient. One patient, after ECT, they went on to develop a pulmonary embolism, and the only potential possible difference there looked like it was it was a proximal DVT as opposed to distal. All the patients with distal DVTs did well. There was another patient with a proximal DVT that did not have a complication, but ECT might be riskier if it's a proximal DVT compared to distal. But obviously we don't have a lot of data to guide us on decisions like this. Patients can get pressure ulcers if they're not moved around, and so it's always important that we're moving these patients when they're not mobile. There can be impaired secretion with catatonia. I've seen this once. It was really strange, but the patient just could not clear their secretions. And there are a couple cases here, one where a patient got ECT and that problem went away. So it seems like for some people, catatonia seems to impair their ability to clear their respiratory tract. Contractures can also occur, and it's disheartening to see this. Sometimes patients come in with this, so they've had catatonia for long periods, and the contractures aren't going to go away. So that's another reason why it's important to recognize this early and get it under control, because if you don't, then patients might have to live with these malformations for the rest of their life. This was an interesting case report of nutritional deficiency. So the patient had catatonia, they had withdrawal, so they weren't eating. They developed a vitamin K deficiency because they were also on antibiotics. And so you can see strange complications like this. Neuroleptic malignant syndrome. So, this is something that we worry about with antipsychotics in catatonia. In the 1990s, there was an abstract presented on this that showed that 4% of patients with catatonia who were treated with antipsychotics went on to develop NMS. More recent data shows that the number is a lot less now, and I think that's due to the advent of second generation antipsychotics. It does seem like second generation antipsychotics, they do not exacerbate catatonia for most patients who have it. And if you think this through, that makes sense, since only about 10% of patients with catatonia are getting diagnosed. Most oftenly, it's misdiagnosed as some sort of psychosis. So there are, literally tens of thousands of patients across the country being treated with antipsychotics who have catatonia, and our ICUs are not overflowing with patients with NMS. So I think in general, second generation antipsychotics are reasonably safe in patients with catatonia, but obviously they're not the first medications that I'm going to use in these patients. Malignant catatonia, I talked about this earlier, so I'll skip that. Catatonia is associated with risk of premature death in a variety of populations. So there was a study looking at patients with catatonic schizophrenia over 7 years, and that found that their relative risk of death was 3 to 4 times higher than the general population, and a good chunk of this was from suicide. But there were a lot of patients who died from other causes of death as well. Another study looked at this in catatonic stupor. So this was a couple thousand patients admitted to a psychiatric hospital. About 8% of them were diagnosed with catatonic schizophrenia. And again, they had a much higher rate of premature mortality. And the rate of mortality during the hospitalization was much higher for catatonic patients than non-catatonic patients. And so 10 of the patients out of the 140 died during the hospitalization, and the most common cause was pneumonia and arrhythmia. This has also been looked at in adolescents. This is a small sample, so I don't think the actual number is probably this high. But what they found was that over a follow-up period of 4 years, among the 31 patients, 3 of them died, and 14 of them needed continuous psychiatric care. So catatonia in adolescents can be particularly devastating. But this found that catatonia was associated with a 60 times increased risk of premature death when compared to the general population. So that there's a very high risk in adolescents, but I do think if there was a bigger population, the number probably wouldn't be quite as high, but still would be alarmingly high. We're just now in the last few years starting to get economic data on catatonia. So this has been done by Lucarelli and colleagues, and they've been using nationwide hospitalization data sets to look at this. And what they found was that a large percentage of patients with catatonia who are hospitalized, about 40%, are not discharged home afterwards. So many of these patients are being discharged to nursing homes. 1% of them died in the hospital. They stayed about 10 days, and this is just general medical hospitalizations. And the cost of the hospitalization was typically around $50,000, and that totaled up to about $1 billion of care for patients with catatonia in a single year. And this is almost certainly an underestimate, but it's obvious that this is a costly condition. And more than a third of patients had a procedure, with ECT being the most common procedure, followed by lumbar puncture and EEG. They did a similar study recently in children. Catatonia was diagnosed less often in children than adults, not surprising. More of those patients were able to go home, but still about a fifth of them had to go to another healthcare facility that was not an acute care hospital. Similar median length of stay and charges. And catatonia was found to be among the most costly pediatric mental health disorders. Almost half of patients had some procedure. So it was usually lumbar puncture, EEG, or MRI, since ECT is used less frequently in children. And so, what does a patient's catatonia tell you about their future? Unfortunately, it is a rather negative prognostic sign. If they do have a psychotic condition, then they're more likely to have more severe psychotic psychopathology and negative symptoms. And in addition to the increased mortality risk, there was another study that showed having catatonic signs at the initiation of treatment, if you have psychosis, is associated with poor long-term psychosocial functioning. All right, so now I'm just going to talk about management of catatonia and complications for the last 10 minutes or so. So this is from a paper that was published in 2018 that presents a treatment algorithm for catatonia. So I think this is a very, very useful paper, but essentially what it says is, if a patient has some sort of behavioral issue or altered mental status, then you want to do a physical exam. And if that suggests catatonia, then you want to treat with the lorazepam or zolpidem challenge. If they don't respond to that, or they fall asleep, you want to think about potential mimics of catatonia or delirium. However, there are patients who do get sleepy from benzodiazepines who have catatonia. They're in the minority, but it can happen. And sometimes benzodiazepines don't work for catatonia. So just because they fail the Ativan challenge test does not mean that it's not catatonia. But in cases like that, you can consider memantine or amantadine. If it does improve, then you want to continue to increase the lorazepam they recommended up to 24 milligrams a day. And if they're not fully responsive to that, if there are malignant syndrome features, you want to go on to consider ECT. If there are not malignant features, then you would consider augmenting with memantadine or amantadine, or switching to zolpidem. You can also use stimulants. I've had some luck with treating catatonia with stimulants, but it's always kind of tricky since many of these patients have psychosis, and it can make the psychosis acutely worse, which is problematic on inpatient units. Check the iron. If the iron level is normal and there's no history of NMS, then you could also consider augmentation with lower potency second generation antipsychotics if they're not fully responding. So I'll go into that in a little bit more detail here. So this is the lorazepam challenge. So typically, if you're going to do this, you're usually going to do it with IV, but you can do it with other routes of delivery as well. But it's 1 to 2 milligrams IV. If you're giving it IV, you evaluate them after 5 minutes because there can be very quick improvement. If there's no improvement, you want to administer a second dose and reassess. And if there is going to be a response with IV, it often is pretty quick within 10 minutes. But if you're using IM or oral, then you have to increase your interval and check 15 minutes if it's IM, or check 30 minutes if it's oral. But like I said, if it's positive, that means catatonia. If it's negative, that does not mean that it's not catatonia. And this was a cool case report here of a patient in India, I believe, who had catatonia for 17 years and was finally treated at a hospital and responded to the Ativan challenge. So this is a very, very powerful treatment for some patients. So lorazepam is the first-line treatment for catatonia, regardless of the underlying condition. It's probably less likely to be helpful in chronic catatonia. It's preferable since it has more GABA A agonism than other benzodiazepines. And most patients, when you're doing this, we do 3 times a day dosing and just gradually increase the dose. Potentially, I've seen case reports of up to 30 milligrams total per day. I think the highest that I've used is something like 21 milligrams. Um, Often, patients will not be sedated by benzodiazepines if they had catatonia, but there are exceptions, and I've certainly seen that. We've had to use memantine or ECT in those patients. If you're treating them orally, you'll usually see resolution of the catatonia over the course of a few days. So not everybody has that dramatic effect to the Razapam challenge. Sometimes it does take a few days to get this under control if you're not using the IV route. And it's also not uncommon for patients to leave with residual catatonic signs. You're not treating to try to get every single sign resolved. You're treating to functionality. And this table here has response rates for lorazepam in catatonia with a variety of underlying diagnoses. And you can see there that it's often a very highly effective treatment, although it's less effective if the patient has schizophrenia. So in general, what I've seen in clinical practice is that once the catatonia resolves or mostly resolves, teams tend to quickly taper lorazepam. And this is what I used to do. And then I stopped doing this because so many patients were bouncing back to the hospital. Now I send everybody out on a taper of lorazepam over the course of a few weeks to ensure that they don't relapse. There's not good evidence to guide this. There are no RCTs or even observational studies that I'm aware of, but that's been my experience. And now I just send everyone out on a taper. I think the risk of recurrence of catatonia is far more potentially devastating than the odds of them becoming dependent on lorazepam. As I said before, patients with recurrent catatonia may need lifelong standing benzodiazepines. I know there's a lot less benzodiazepine use in the field these days. Pharmacies get very worked up about the use of benzodiazepines, especially if it's a patient with catatonia and they're on a high dose. But you have to call and advocate for these patients, and there's nothing inappropriate about starting someone on a standing benzodiazepine if they have recurrent catatonia. There are many case reports of patients successfully treated with other benzodiazepines. And I've had some success myself when lorazepam wasn't working, switching to other benzodiazepines. And so, it's not something that I do commonly, but everybody's pharmacology has variability, and so there do seem to be some patients that don't follow the rules. That lorazepam is the best. So sometimes that can be helpful switching. Zolpidem can also be helpful. I've had patients who were not responsive to benzodiazepines, and we actually developed an order set here to order Zolpidem for catatonia. So it's dosed 3 times a day, and so we'll do 5 milligrams 3 times a day, and then move that up to 7.5 or 10 or 12.5 3 times a day if benzodiazepines aren't working. And it makes sense that this works because Zolpidem is a GABA A agonist. It's a little more problematic to discharge people on Zolpidem than benzos. I found, though, you often have to do prior authorizations because you're using a high dose, and pharmacies also kind of get upset about this. ECT, of course, is gold standard treatment if benzodiazepines aren't working. Has really, really high response rates. It should be first line treatment if you're treating a patient with malignant catatonia, NMS, delirious mania. Concurrent neurological disorder is a predictor of non-response to ECT. So occasionally there are patients that don't respond, but you really need to do like 30 sessions of ECT or potentially more before you call a patient non-responsive to ECT if they have catatonia. Patients who do respond to ECT can relapse. There was a study here that found about half of them had catatonic relapse within a year. So many patients who respond to ECT with catatonia are going to need maintenance treatment as well. And this was an interesting case report here that found a pretty striking increase in cerebral perfusion in a patient with catatonia after they got ECT. All right, so I've touched on this a little bit, but antipsychotics for catatonia, this is often an area that makes people nervous, but I don't think that black and white thinking here is helpful. There are patients with catatonia who are going to need antipsychotics for agitation. You have to have things available for the nurses. When someone's not there overnight, obviously you want them to use benzodiazepine first line, but sometimes that's not enough, especially if it's excited catatonia. So there was a study that looked at patients who had catatonia who had never been on an antipsychotic, and so they had non-affective psychosis. So 12% out of that cohort had catatonia, and they did a sub-analysis, and they found that after antipsychotic treatment, the proportion who had catatonia dropped from 12% to 2%. And you can see that over here, the p-values. This was statistically significant, for a variety of dimensions of catatonia. So it looks like for many patients, antipsychotics actually will treat their catatonia. But if you're going to do it, there's risk. You are taking some risk in doing this, and so I recommend using low potency second generation antipsychotics and using a low dose. These are patients that I try to keep away from Haldol and Prolixin and things like that, and I will put that in the note. If you're going to use antipsychotic, use imgiadon or something like that. Antipsychotics do look like they can hinder treatment with benzodiazepine. So this was a study where they had patients with catatonia who were receiving benzodiazepines and antipsychotics, and the patients who did not have concurrent antipsychotics had more of a response as opposed to patients who had both benzodiazepines and antipsychotics. And so that's the thing about antipsychotics with catatonia is, for the most part, it doesn't seem like it makes things worse. It will treat catatonia for some patients, but then there's just going to be some patients where it absolutely does make things worse and might make their condition resistant to treatment. It's also been found that patients who are taking antipsychotics who have catatonic schizophrenia have higher rates of negative symptoms or negative symptom exacerbations from their antipsychotic. And so in general, I think it's best to avoid, especially first generation antipsychotics in patients with catatonia, even if they're outside their episode and you're treating them later. Alternative treatments, mentioned some of these when I went over that algorithm, but NMDA receptor antagonists are very, very useful. Essentially what I do now is I start all patients, if they're willing, I start them on lorazepam and memantine together. Memantine is it's a very well-tolerated medication with minimal risks, and so I've seen a synergistic improvement in patients by just going ahead and starting that. You can also use amantadine, but it does have potential to worsen psychosis, so I use that less often. Barbiturates can be useful if for some reason a patient is not responding to benzos. I've used phenobarbital once in a very, very complicated case. It did appear that it might have worked, but the patient was also getting ECT and was on clozapine, so it was very complicated and hard to figure out what was happening. There's some evidence for mood stabilizers as well. I think lithium in general is very, very helpful long-term for these patients. And then I mentioned stimulants, haven't used them a lot, but sometimes they can be helpful. And then there are case reports of TMS and ketamine potentially being helpful. I've treated 3 patients with catatonia with ketamine and I have not seen worsening, but I didn't see dramatic improvements, and so I haven't seen anything consistent with this case report yet. Finally, I'll just wrap up by talking about guidelines on preventing complications. So for DVT, you want to consider starting prophylaxis with heparin or enoxaparin. Pressure ulcers, have the nurses do skin evaluations on these patients, use a standardized scale, reposition them frequently, use air mattresses if you have those available. With the muscle contractures, do range of motion, stretching exercises with patients. Nutritional deficiencies, sometimes you do have to use feeds, tube feeds with these patients, but that's very, very rare. that's a complicated decision where you have to take a lot of different pieces of information into account. And then with pneumonia, make sure these patients are walking, and encourage them or assist them in brushing their teeth. There haven't been studies of this in catatonic patients, but it's pretty clear that in ICUs, there are reduced rates of pneumonia in patients who are on ventilators when their teeth are brushed. So I think, given the risk of aspiration pneumonia, that's an important consideration in these patients as well. And that's it. So yeah, happy to take your all's questions.
All right, if you guys want to raise your hand, I can promote you to panelist so you can ask your question. Let me see. Brian, I see you. Nick, I see you. Or feel free to put your question in the Q&A below, and I'll be happy to read it. And Dr. Lippman, I see you. All right, go ahead, guys.
Thank you, Dr. Barnett. I appreciate your lectures. It was actually very informative. I have one particular question. So when it comes to the benefit of maybe using an atypical antipsychotic versus a typical antipsychotic, why do you think that atypicals seem to be better for treating catatonia? Or at least they're less harmful?
I think it's probably since the first generations are more strongly anti-dopaminergic, and so I think that makes sense. That would worsen a movement disorder like this.
Do you have any thoughts on whether or not isolated, like serotonin 2A antagonism, would help catatonia?
I think that's a good question. I haven't seen any studies of that, but I mean, I would suspect that that aspect of the second generation antipsychotics is probably helpful in some way. But yeah, I haven't seen like any like neuroscience type studies looking at that.
Thank you. One of the theories that a lot of us are fond of here at U of L is the depolarization theory of catatonia, which suggests that elevations in resting membrane potential leads to depolarization block. So if you look at something like dopamine, D2 specifically, what it does is it affects potassium channel function. It ends up opening it so that you end up releasing potassium low in resting membrane potential. Serotonin does the opposite. If you stimulate serotonin 2A, it closes that potassium channel. It elevates resting membrane potential. And most of the treatments kind of make sense on a membrane potential depolarization model. So I was just curious if you thought that was reasonable. I talked with Dr. Francis for a couple hours about it a few weeks ago, and he thought it was interesting, at least.
Yeah, that sounds reasonable to me. I mean, I'm not a neuroscience researcher. Primarily do clinical research, but yeah, that sounds like it would be something that would make sense.
Thank you.
We have a question from one of our residents, Mel. She said, any reports of brexanolone for catatonia?
No, that's a great question. I think it would make sense since it is a GABA A agonist, but I have not seen anything yet. But it's probably just a matter of time before someone tries it. But it's at this point probably a very expensive alternative to using lorazepam. But once that goes off patent, I imagine that's something we'll probably be using for catatonia pretty frequently.
And another question from Syed, who's a PGY4 resident. He says, regarding rates of coagulopathy and catatonia, have you come across any research that supports the presence of pathological changes in coagulation cascades that increases the risk other than immobility alone?
There is a paper, I think it was in Lancet Psychiatry, looking at catatonia as an immune disorder, and I think it does get into some of that. But yeah, I do think that the risk of things like DVT and PE is not just due to patients being hypomobile. with elevated rates of D-dimer and some of those other labs that I showed, I think that there, there's definitely something going on, to increase the coagulation cascade.
Dr. Barnett, big fan of your work, read a number of your articles, and really excited for the work that you're doing. I guess my question was specifically around trauma and how that might relate to catatonia. I remember a case when I was a medical student of I think she was 14 or 13 years old. She came in with all the classic signs of catatonia. And I mean, like echolalia, echopraxia. I mean, she had a very high Bush Francis, and it was really the first time that I've ever seen a case, not necessarily from severe mental illness per se, but from direct trauma. This patient had been sexually trafficked fairly recently, and the mother was suspicious, wasn't sure, and then it became confirmed. So I was really just curious if you had any thoughts on trauma and its association with catatonia.
Yes, nice to meet you, Ryan. Um, as far as I know, I think there's only one study that's looked at this. It was, I believe it was on an inpatient psychiatric unit, but they did an assessment, Bush Francis assessment on those patients. I think it was just in patients who had PTSD, and they did find a much higher rate of catatonia than one would expect. But this is a very under-researched area in catatonia. So I think I'm not exactly sure why, but it does seem like it's been very neglected. I mean, maybe because we, tend to think of catatonia as more, biological than other psychiatric conditions. The field hasn't really made that connection. I think there's a lot of important work to be done there.
Thank you.
We have another question from some of our PGY1 residents. What's the evidence behind having an autoimmune process associated with catatonia, and is there any role for immunosuppressive therapy for treatment?
Well, I think, what's really gotten people thinking about this in the last decade or so is the kind of the emergence and recognition of autoimmune like anti-NMDA receptor encephalitis. In being able to more easily recognize that now with the growing recognition, it raised the question of how many of these patients with catatonia in the past had this condition, and the catatonia was just a manifestation of that. But the changes that I showed in things like white blood cell count, the ratio between the neutrophils and white blood cell counts, it's pieces of evidence like that that are making people increasingly think that for some patients, catatonia might just be the outward manifestation of an autoimmune disorder, and we do see higher rates of it in patients who have things like lupus and other autoimmune conditions. And so there does seem to be some link there for at least some patients. But I think that's the challenge with catatonia is it's like delirium. It's never, it's always caused by something. And so in some patients that could be a seizure, in some patients it could be bipolar, and other patients it could be autoimmune. In terms of like how big of a chunk the patients where it's being driven by autoimmune disorders is, that still remains to be seen.
Dr. Rabbani, did you have a question?
Yes.
Okay.
Thank you very much for the talk. I enjoyed it. I learned a lot. My question, I have a few small questions. One of them is that, have you noticed any effect on swallowing muscles? Like catatonic things on swallowing, not to be able to swallow?
That's not something that I've seen a lot. I can think of one or two cases where it did seem like that was happening though, and those were cases where we had to do artificial feeds for patients. So I think that is a possibility, but though very rare.
How do you kind of recognize it? So that is something that we should be looking for it. I mean, that may cause malnutrition, not to be able to swallow and eat. Okay, my other question was about, you mentioned the neutrophil ratio to lymphocytes, and that if that increase, that is, you linked it to maybe autoimmune disease. However, in any excitement, that ratio may increase because neutrophils usually are marginated in the vessels, and when they get the blood, the neutrophils come to the mainstream bloodstream, and it would increase. So in any excitement, that ratio can be increased, like in mania, in any. So that cannot be kind of a reason for autoimmune disease, I think. And then my other question is about the negativism, that if a patient comes and is not cooperative to answer my questions, sometimes they are angry, they don't want to come to emergency room, or sometimes they are depressed, they don't want to talk about this. So that cannot be, how can that be a sign of catalepsy, or how can you differentiate that?
Yeah, I think sometimes it's a challenge, but you have to use all the information that you have, and so that's where chart review can be really helpful when the nurses are making observations of these patients. I also do like to get a look at them, from the doorway when they're not aware that I'm looking, and often you'll see them doing strange things, mannerisms, stereotypies, but it's I would say it's unusual, for someone to refuse an exam for days straight, no matter how mad they are or how depressed they are. Even if you tell them, like, I need to examine you so we can get you out of here. The catatonic patients, if they're in a really negativistic state, they can be extremely obstinate and just totally uncooperative. And so I think it's a level of degree that often tips me off to catatonia, rather than just routine uncooperativeness that you sometimes see on the units. But I think too, your electronic medical record can be very, very useful here, especially if these are patients who've been in your system for a long time. That's when I start to search for some of those phrases that I had showed there. From other stays before, if things were being recognized at previous hospital stays where patients were having periods of mutism or catatonic excitement, things like that. And I often find that in cases like that, where I'm doing this digging, that it looks like patients have had catatonia in the past.
Thank you very much.
All right, everybody. It's 1 o'clock, so we have to let everyone go. Dr. Barnett, thank you so much for your time and for speaking to us. Would it be okay if I passed along your email to our residents if they have any questions for you or anything like that?
Of course. And yeah, thank you all so much for the opportunity to talk about this and for the great questions.
All right. Thank you so much. Everyone, have a good day. Bye now.
Take care.